Hello friends, today we are going to discuss the topic of facial nerve. Now to understand the diseases of the facial nerve, it is very important for us to first know the anatomy of facial nerve. So in this topic we are first going to study and understand the anatomy of facial nerve before we go ahead with the diseases of facial nerve. Okay, so let's study the anatomy of facial nerve. Facial nerve is the seventh cranial nerve, right? And this nerve is a mixed cranial nerve. So what do we mean by mixed cranial nerve? With the meaning of mixed, we mean that it has three functions. Which three functions? It has sensory function, it has motor function, and it has secretomotor function. Okay, so three functions: sensory, motor, secretomotor function. So that means to do these functions, we have three nuclei also in the facial nerve. So what are the three nuclei? For the sensory function, we have the nucleus tractus solitarius. For the motor function, we have the motor nuclei. Okay, and for the secretomotor function, we have the nucleus salivatorius superior. You can also call it as superioris, right? So we have these three nuclei. From here the facial nerve originates. All right, so let's do one thing. Let's draw a diagram and study the complete anatomy of the facial nerve. All right, so let's understand all this in the form of a diagram. Okay, so the facial nerve you see over here, it starts from its motor nuclei. All right, so this is the motor nuclei of the facial nerve, and this nuclei is in the pons, that is, it is in the brainstem, right? So this is the motor nuclei, and from this motor nuclei, the fibers, the facial nerve comes out and it travels in the cranial cavity. Okay, so it travels upwards. You see, it travels first upwards. It takes a turn. It takes this turn around the sixth nerve nuclei, the abducens nerve nuclei, and then it comes back. Okay, so then it comes back and it enters into the internal auditory canal. Okay, so it comes back and it enters over here into the internal auditory canal or internal acoustic meatus, right? Okay, so this is the first segment of the facial nerve. We call this first segment of facial nerve as intracranial segment. Okay, this is known as intracranial segment. Now, what we have learned in the intracranial segment, instead of coming down, the facial nerve first goes up in the brainstem. Okay, then it takes a turn around this sixth nerve nuclei. So that means if there is a lesion at this place, okay, if there is a lesion at this place, now both the sixth and the seventh nerve, they will be involved together. Okay, the sixth and the seventh nerve, they are involved together, and this is known as Millard-Gubler syndrome. Okay, so MCQ question over here. So sixth and seventh nerve are involved together. This is your Millard-Gubler syndrome, right? Okay, now the facial nerve enters into the IAC, internal auditory canal, also known as internal acoustic meatus, right? This IAC or IAM, where is it? Remember, this is in the petrous temporal bone. Okay, remember the IAC, it opens in the posterior wall of petrous part of temporal bone. We discussed that in the very beginning in the osteology of the temporal bone, right? So this canal, this internal auditory canal, what is passing through it? The seventh cranial nerve, the facial nerve. Now along with this, we also have the eighth nerve. Remember, the vestibulocochlear nerve. So we will be studying this IAC in detail in this topic. All right. So first see that the IAC, now we have the facial nerve going into this IAC inside the temporal bone. Okay. Now here it is traveling along with the 8th cranial nerve. So that means if there is some tumor, there is some lesion over here, both 7th and 8th nerve will be involved together. Okay. And this segment of the facial nerve, this segment is known as segment 2, that is your intrameatal segment. Right, friends? So this is your intrameatal segment, the segment inside the IAC or IAM. Now, till now, I have discussed with you only the motor fibers. You see, this is coming from the motor nuclei. As I told you earlier, there are 2 more nuclei. Which 2 nuclei? Sensory nuclei and secretomotor nuclei. Okay, nucleus tractus solitarius and nucleus salivatorius superioris. Okay, so that means we have 2 more nuclei. So let's do one thing. Let's talk about them. Right. So we have over here the sensory nuclei. This is nucleus tractus solitarius. Okay, and we have the secretomotor nuclei, nucleus salivatorius superioris. Okay, now both these nuclei, they give nerve fibers. Now these nerve fibers, they come and combine together. Okay, so when they combine together, now they form a nerve. This nerve is known as nerve of Risberg. Okay, this nerve over here, this nerve is known as nerve of Risberg. Okay, you can also call it as nervus intermedius, nerve of Risberg or nervus intermedius. Okay, so this nerve of Risberg or nervus intermedius, it goes and combines the facial nerve in the intrameatal segment. And now you can see over here the facial nerve, it now becomes a mixed nerve. So the facial nerve becomes a mixed nerve inside the IAC or IAM in the intrameatal segment. Right? Okay. So now the facial nerve, you see, it crosses the meatal foramen. So over here, this is the meatal foramen. So the IAC or IAM, it ends at the meatal foramen. And thereafter, the facial nerve, once it crosses this meatal foramen, it enters into the temporal bone. Okay, so when it enters into the temporal bone, now this is known as segment 3, that is the intratemporal segment of facial nerve. Right? So this is the intratemporal segment of facial nerve. Okay, when the facial nerve crosses the meatal foramen and enters into the temporal bone. Right? Okay, now this meatal foramen, this is the nervous part of the whole facial nerve anatomy. Okay, this is the nervous part of this canal also. Okay, you see, after this meatal foramen, the facial nerve, it enters into a bony canal in the temporal bone. As we discussed during the middle anatomy, when the facial nerve is traveling in the intratemporal segment, the facial nerve is actually traveling in a bony canal. The name of this canal is fallopian canal. Okay, and this is the longest bony canal for any cranial nerve. So 7th nerve, facial nerve, has the longest bony canal, and the length of this canal is 27 millimeters. Longest bony canal for any cranial nerve. Okay, so the facial nerve inside the temporal bone is in this fallopian canal, and the narrowest part of this fallopian canal is the meatal foramen. Okay, this meatal foramen is only 0.68 millimeter in diameter. How much? 0.68 millimeter in diameter. Okay, so that is the narrowest part of the fallopian canal. Now, from here, you see the facial nerve is in the temporal bone. Now it takes a sharp turn. So you see over here, it takes a sharp turn like this. Okay. Now, when it takes the sharp turn, this turn over here, this is known as first genu. Okay. So we call it as the first genu. Now, at the first genu, we have a ganglion, right? So at this genu, we have a ganglion inside the nerve, and that ganglion is known as geniculate ganglion. All right. So you see, we have the first genu over here, and over here in the first genu, we have the geniculate ganglion. Right? Okay. So now the facial nerve takes a sharp turn. This part of the facial nerve, which is between the meatal foramen and the first genu, the geniculate ganglion, this part is now named as segment 3A. Okay, so now this is known as segment 3A. Segment 3A is the labyrinthine segment of facial nerve. Okay, so this is your labyrinthine segment of facial nerve. Now, labyrinthine segment of facial nerve, this is the shortest and the narrowest segment of facial nerve. Okay, it is only 3 millimeters in length, and diameter we have just discussed. The diameter is 0.68 millimeter right at the start at the meatal foramen. Okay, so this is the labyrinthine segment, the shortest segment of facial nerve. Okay, now the facial nerve takes a sharp turn, all right, and it runs horizontal over here. This segment of the facial nerve, okay, this segment of the facial nerve is known as segment 3B. Okay, what do we call it? We call it as the horizontal segment of facial nerve. So that is your segment 3B. Okay, so I will cover this segment. Let's first complete the diagram of the facial nerve. So let's quickly draw it, and what we can see over here, I draw this diagram of the facial nerve, and you will have the anatomy which is a recognizable anatomy for you. Okay, the anatomy that we have already discussed. Okay, so what we can see over here? We can see over here the facial nerve the segment 3B. So I hope by now you have recognized that this over here is the anatomy of the middle ear. Okay, so we discussed the anatomy of the middle ear, the anterior wall, the medial wall, the posterior wall. Okay, so we can see over here the oval window, the round window, and now we know segment 3B. What is segment 3B? The segment 3B is the horizontal segment. We also call it as the tympanic segment of facial nerve. Okay, and this takes a sharp turn. So when this takes a sharp turn over here, this is known as second genu. right? Remember, this is second genu, right? And when it takes a sharp turn over here, now it becomes segment 3C. Okay, this segment 3C is the vertical segment of the facial nerve. Okay, we call it as the mastoid segment of facial nerve. Right? I hope you remember. And now this mastoid segment of the facial nerve, if you remember, it crosses over here the meatal foramen. You see, so there is a meatal foramen over here, and it crosses the meatal foramen. This vertical or the mastoid segment of the facial nerve, it crosses the foramen over here. Which foramen? It crosses the stylomastoid foramen over here. So we can see we have a foramen over here, that is your stylomastoid foramen. Okay, so it crosses the stylomastoid foramen and it goes out of the temporal bone. Okay, so when it goes out of the temporal bone, now this is known as segment 4. Okay, the segment 4 over here is your extratemporal segment. Okay, so that is your extratemporal segment of facial nerve. Right, so this is the anatomy of the facial nerve. Quite easy anatomy, not a big problem. Okay, let's revise and learn this anatomy. Now, you see, how can we learn this anatomy? To learn this anatomy, we have a formula. Now, this formula is based upon dance. Okay, I call it as the dance of the facial nerve. How? You see, whenever we learn dance, whenever we go to learn a choreography for a dance, the dance is always taught as numbers. So suppose you have to learn a dance, your dance instructor will teach you like 1, 2, 3, 4. So you have to move 1, 2, 3, 4, 5, 6, 7, 8. You come back. Okay. Or he can teach you 1, 2, 1. Right. He can teach you 1, 2, 1. Then again 1, 2, 1. So you have to keep on repeating the steps. So 1, 2, 1. Like that. Okay. Now same way I call the dance of the facial nerve as like 1, 2, 1, 3, 4, 3. So I call it as 3, 4, 3. Okay. The anatomy of the facial nerve can be learned by the sequence. The dance sequence is 3, 4, 3. So what is this 3, 4, 3? Okay. What is this anatomy 3, 4, 3? Now 3 are the nuclei. Okay. Which 3 nuclei? Motor nuclei in pons, nucleus tractus solitarius, that is for touch, and nucleus salivatorius superioris, that is the secretomotor nuclei. Okay. Now, how many segments are there in the facial nerve? 4 segments. Which 4 segments? Intracranial, intrameatal, and intratemporal. Okay. So remember, the intertemporal has the fallopian canal, okay, the longest bony canal, 27 millimeter. And then we have the 4th segment, the extratemporal segment. So 3, 4, and then finally 3. The 3rd segment is divided into 3 more segments. Okay, the first is the labyrinthine segment, which is the shortest and the narrowest segment, 3 millimeter length and 0.68 millimeter diameter. The narrowest segment. Okay. Then we have the tympanic or the horizontal segment. This segment is approximately 11 millimeters. The mastoid or the vertical segment, which is approximately 13 millimeter. But these are not significant. What is significant is the labyrinthine, the shortest segment, or the fallopian canal, total length 27 millimeters. Right. So this is the entire anatomy of the facial nerve. Okay. Now let's do one thing. Let's study the branches of facial nerve. Okay. So I hope you have understood the anatomy. Let's go and understand the branches of facial nerve. So let's go back to the diagram that we have drawn. We come back to this diagram of the facial nerve. So this all we have drawn. This is the anatomy of the facial nerve. Now let's come to the branches of facial nerve. So now when I say the branches of facial nerve, we should remember that segment 1, that is your intracranial segment. segment 2, that is your intrameatal segment, and segment 3A, that is your labyrinthine segment. Now these segments do not have any branches. So segment 1, segment 2, segment 3A, no branches. Right? Okay. Now we have, what do we have after segment 3A? Yes, we have segment 3B, but before segment 3B, we have over here the geniculate ganglion. Okay, so we have the first genu. At the first genu, we have the geniculate ganglion. Now, at this geniculate ganglion, we have 3 branches. Okay, so remember, 3 branches, they come out of the geniculate ganglion. Okay, how many branches? 3 branches. Which 3 branches? Number 1, we have the GSPN. So what do I mean by GSPN? GSPN stands for greater superficial petrosal nerve. Okay, GSPN, greater superficial petrosal nerve. Then we have the external petrosal and we have the lesser petrosal nerve. Right? So we have the 3 nerves. Now, let's say these nerves are the daughters of the facial nerve. So facial nerve is the mother. There are first 3 daughters. Now GSPN, MCQ question over here. Remember, GSPN is the first branch. Okay, this is the first branch, or you can say the first daughter of the facial nerve. Okay, so this question is asked in the exam. First branch of facial nerve, that is your GSPN, greater superficial petrosal nerve. Okay, now before we go ahead, let's talk about these branches. All right, so let's first talk about the GSPN. So the GSPN, that is your greater superficial petrosal nerve. Okay, greater superficial petrosal nerve. Now this GSPN, it carries preganglionic parasympathetic fibers. Preganglionic parasympathetic fibers. Am I right? Am I right? Listen carefully. This nerve is coming from the ganglion, from the geniculate ganglion. Still I am saying that the fibers are preganglionic. Now why I am saying the fibers are preganglionic? Because these fibers, they do not relay in this geniculate ganglion. Therefore the fibers are still preganglionic. Okay. So now I said the GSPN is the first daughter of the facial nerve. Now where is this daughter born? The daughter is born in the middle ear. Right? But this daughter is an ambitious daughter. She does not like the middle ear. Okay, she says, I want to do MBBS. I want to do from abroad. Okay, so let's say she goes to Russia. All right, so she leaves the middle ear and she goes to Russia to do the MBBS. Okay, so she takes a fissure. She takes a fissure. Which fissure? Petrotympanic fissure. You see, petrosal nerve, tympanic cavity, leaves a tympanic cavity. So petrotympanic fissure. So she takes a petrotympanic fissure, and through this fissure, she goes back into the middle cranial fossa. Okay, so she goes into the middle cranial fossa. So that is the place where she tries to do her MBBS. Now, there is another nerve. This nerve is the deep petrosal nerve. This nerve is also from India. Okay, so let's say middle ear is India. Okay, now this nerve, it originates from the tympanic plexus that is in the middle ear on the medial wall. Okay, so it arises from the tympanic plexus that is on the promontory. Promontory means it is on the medial wall of middle ear. Now this petrous nerve, the deep petrosal nerve, this nerve, it carries sympathetic fibers. Okay, so the deep petrosal nerve is carrying sympathetic fibers. So GSPN has gone to do MBBS. The deep petrosal nerve has also gone to do MBBS. Both of them have gone to do MBBS in Russia. Right? Okay, so now the GSPN meets this guy, deep petrosal nerve over there. Now this is a sympathetic guy, complements the GSPN. So he has what she does not have. She has parasympathetic fibers, he has sympathetic fibers. Okay, so both of them, they fall in love with each other and they get married. Okay, so they get married and now they are known as Vidian nerve. Okay, now they are known as Vidian nerve. Now this Vidian nerve decides to do post-graduation. You see, this is pre-ganglionic. They have to become post-ganglionic before they can do anything useful. So similarly, you guys also have to do your post-graduation. Nowadays, just plain MBBS has no value, right? So you have to do post-graduation. Even this Vidian nerve has to do post-graduation. Okay, it has to convert its fibers into post-ganglionic fibers, right? So this Vidian nerve decides, let's do post-graduation from some other university. So now they go through a canal. Okay, they go through a canal. Which canal? That canal is known as pterygoid canal. Okay, so that canal is known as pterygoid canal. It is in the sphenoid bone. Okay, the Vidian nerve crosses the pterygoid canal. So this canal is also known as Vidian canal. And this nerve is also known as nerve of pterygoid canal. Okay, now this canal is present at the base of the pterygoid process of sphenoid bone, right? And when the Vidian nerve crosses this pterygoid canal or the Vidian canal, now this Vidian nerve reaches the pterygopalatine fossa. Okay, it reaches the pterygopalatine fossa. Now, in the pterygopalatine fossa, we have the pterygopalatine, also known as sphenopalatine ganglion. Okay, so we have the sphenopalatine or the pterygopalatine ganglion. This is the largest peripheral parasympathetic ganglion. Okay, largest peripheral parasympathetic ganglion. You remember there are 4 parasympathetic ganglions which are peripheral ganglions. Okay, rest all are central. So the largest among them is the sphenopalatine ganglion. Okay, also known as pterygopalatine ganglion. Now this Vidian nerve relays its fibers over here. So when it relays its fibers, now these fibers, they become post-ganglionic. Now they are fit to function. Okay, and now after this they supply the lacrimal glands. So you see, now they have done post-graduation, which eye? So there were 2 people, remember, husband and wife. So now they have done post-graduation in eye and ENT, ophtha and ENT. Okay, so we have the lacrimal gland, that is your ophtha, and then we have the ENT. So they also supply the nasal glands, and they supply the taste, and they supply the minor salivary glands in palate. Okay, minor salivary glands in palate. So you can see ophtha and ENT. So they have done post-graduation in these 2 subjects, right? So this was your GSPN, the greater superficial petrosal nerve, right? Okay, let's go back to the nerve. So now we have seen the GSPN. Okay, the external petrosal is not that important. Let us study about the lesser petrosal nerve. Shall we? Alright, so let's study about the lesser petrosal nerve. Now this nerve, the lesser petrosal nerve, is a branch of the 7th cranial nerve. Okay, you see, remember, there were 3 nerves born at the geniculate ganglion, 3 daughters, greater superficial petrosal nerve, the external petrosal and the lesser petrosal. Now we discuss about the GSPN. So she was the first daughter. She got all the attention. Okay, so she took all the money, all the attention of the facial nerve and she went to do MBBS. Okay, now the lesser petrosal nerve, she also wanted to do something good. But the facial nerve said, I don't have money for you. Okay, I don't have anything for you because I have given everything to GSPN. So the lesser petrosal nerve, no, she is disheartened. So what she does, she takes help from the 9th nerve. Okay, so she takes fibers from the 9th cranial nerve, that is your glossopharyngeal nerve. Okay, so this glossopharyngeal nerve also gives fibers. Alright, so now this GSPN gives fibers to the lesser petrosal nerve. So thereafter, the lesser petrosal nerve will be known as the daughter of the 9th cranial nerve. She has adopted the lesser petrosal nerve. Okay, so she has told her, don't worry, I give you fibers. So the lesser petrosal nerve has major fibers from the 9th cranial nerve and only very small number of fibers from the 7th cranial nerve. So if somebody asks you lesser petrosal nerve is a branch of, your answer should be glossopharyngeal nerve, the 9th cranial nerve. Okay, now this lesser petrosal nerve, it is born in the middle ear, but it also leaves the middle ear. Okay, so it also leaves the middle ear and it goes to the infratemporal fossa. Okay, it goes to infratemporal fossa. Now in the infratemporal fossa, it goes into a ganglion that is known as otic ganglion. Okay, so she does not go up, she does not go to Russia. So let's say she goes to Thailand. Okay, now in the Thailand, she goes to a university, alright. So that university is your otic ganglion. Now what happens over here? Over here, she also meets a boy. Alright, now that boy name is auriculotemporal nerve. Okay, that boy name is auriculotemporal nerve. Now this is a branch of the mandibular nerve, 5th cranial nerve, 3rd part. Okay, so auriculotemporal nerve is over here in the otic ganglion. Now see, this is not Russia, this is Thailand. So what happens? The auriculotemporal nerve steal all the fibers of the lesser petrosal nerve. Okay, so it steal all the fibers of the lesser petrosal nerve which she has brought to the otic ganglion. Okay, and takes all the fibers. So the auriculotemporal nerve, it takes all the fibers of the lesser petrosal nerve. So lesser petrosal nerve is destroyed over here. Now we have only the auriculotemporal nerve. The auriculotemporal nerve has fibers of the mandibular nerve, the 5th cranial nerve, as well as the fibers of the 9th cranial nerve, the glossopharyngeal nerve. And it goes and supplies the sweat glands. Okay, it goes and supplies the sweat glands which are majorly under the control of the mandibular nerve, and it supplies the, yes, it supplies the parotid gland. Okay, it supplies the parotid gland which are the parasympathetic fibers of the 9th cranial nerve. Okay, so you see the sweat glands are under the sympathetic system. This sympathetic fibers, they are brought by the auriculotemporal nerve through the 5th cranial nerve. Okay, so the 5th cranial nerve has given these sympathetic fibers, so auriculotemporal nerve brings them. Now the parotid gland is supplied by parasympathetic system Okay, this parasympathetic fibers, they are the fibers of the ninth cranial nerve, again brought by the auriculotemporal nerve, right? Okay, so this is the anatomy of the lesser petrosal nerve. Now somebody asks you which nerve supplies the parotid gland. Okay, the answer is auriculotemporal nerve, right? Now somebody asks you which cranial nerve supplies, or the auriculotemporal nerve is supplying the parotid gland, is bringing the fibers of which nerve? So it is bringing the fibers of the ninth cranial nerve, the parasympathetic supply that goes and supplies the parotid gland. Clear? Okay, so there is this difference. Remember to read the exact anatomy of the question before marking the answer. All right. Okay, so that was your lesser petrosal nerve. Let's go back to the anatomy of branches of facial nerve. All right, so this we have studied the three branches: GSPN, external petrosal, lesser petrosal. Okay, now segment 3B. You see, segment 3B, again no branches. You see, there were branches at the first geniculate ganglion, but in the segment 3B, there are no branches. Now this segment 3B takes a sharp turn. You see, this sharp turn is known as second genu. Now just after the second genu, we know over here we have the pyramid. Okay, now from this pyramid, we have a muscle. Which muscle? That is the stapedius muscle. It starts from the pyramid, and this stapedius muscle, it goes and inserts on the neck of stapes. Remember? Okay, so from here it gives a branch. The facial nerve gives a branch, right? This branch is known as nerve to stapedius. It is known as nerve to stapedius. This is the first motor branch of facial nerve. Okay, remember GSPN was the first branch. This is the first motor branch of facial nerve. Okay, first motor branch of facial nerve, nerve to stapedius muscle, right? And now the facial nerve goes down. In the vertical segment, it goes out of the stylomastoid foramen. Now, before it goes out of this stylomastoid foramen, it gives a branch. Okay. Now, this branch of the facial nerve, it runs in the reverse direction. So, you see this branch comes backward like this. Okay. So, it comes backward and it comes into the middle ear from the posterior wall, right? It comes into the middle ear from the posterior wall, hangs in the middle ear like a cord, like a rope. Okay, so we have already discussed what's the name of this branch. The name of this branch is your cauda tympani. Runs in the tympanic cavity, hangs in the tympanic cavity like a cord, like a rope. Okay, so that is the next daughter of the facial nerve, cauda tympani. Okay, comes into the middle ear from the posterior wall, goes out of the middle ear from the anterior wall. Now, before it goes out, it gives a hug to the whole family. You know, she was the youngest daughter in the middle ear. So now, before going out, she is crying. She wants to go out, but she is also crying. So she gives a hug to everyone. Okay, so this canal is named after that hug. That canal is known as canal of Huggier. Okay, you can also call it as canal of Huggier. That's the actual name, canal of Huggier, but I remember it as canal of Huggier. So it gives a hug to everyone, and then it goes out of this canal, okay, again into the infratemporal fossa, right? Okay, so now what happens to this cauda tympani nerve? Now you see this cauda tympani nerve has been sent by facial nerve. Okay, why it has been sent by facial nerve? It has been sent by facial nerve into the infratemporal fossa. Okay, so why it has been sent? To take revenge. Revenge of her elder sister. Which sister? Lesser petrosal nerve. Okay, remember the lesser petrosal nerve was killed in the infratemporal fossa. So chorda tympani nerve comes to take the revenge of the lesser petrosal nerve, again comes into the infratemporal fossa. Okay, but here she is not able to go into the otic ganglion. Okay, here she meets a guy. Okay, now his name is lingual nerve. Lingual nerve is the brother of the auriculotemporal nerve. So when I say brother, that means is a son of mandibular nerve. Okay, so lingual nerve is the son of mandibular nerve. Again, the brother of auriculotemporal nerve. So she meets lingual nerve, chorda tympani nerve meets lingual nerve, but instead of taking revenge, she falls in love. Okay, but she is scared of the lingual nerve, so she says, I will not marry you. Okay, so she does not marry the lingual nerve, but they go into a live-in relationship. Alright, so this nerve is now known as lingual nerve. It has also the fibers of chorda tympani. So chorda tympani has not lost the identity, okay, but they are staying together. Right, now this lingual nerve and the chorda tympani, they go and they relay in the submandibular ganglion. Okay, so they relay in the submandibular ganglion. Again, the chorda tympani fibers, which were preganglionic parasympathetic fibers, now they become postganglionic fibers. Right, and thereafter she gives supply to submandibular and sublingual salivary glands. Okay, so she gives the parasympathetic supply, the secretomotor supply to submandibular and sublingual salivary glands, and she also supplies the taste to anterior 2/3 of tongue. Right, but you know, along with it, what was traveling? Along with it, we had the lingual nerve which was traveling. So chorda tympani has taken the help of lingual nerve, but lingual nerve has its own fibers also, and these fibers, they also go to tongue, where they give the other sensory supply such as the touch, the temperature. Okay, so all that is supplied by the lingual nerve in the anterior 2/3 of the tongue. Right, so taste is supplied by the chorda tympani in the tongue, but the remaining is supplied by the lingual nerve, that is the fifth cranial nerve. So this is the anatomy of chorda tympani nerve. All right, let's go back to the previous diagram. So now we have come to the previous diagram, and we can see the facial nerve has gone into the extratemporal compartment. So the facial nerve says, I sent chorda tympani, she has not taken the revenge, I should go myself and take the revenge. Okay, so from whom she has to take the revenge? She has to take the revenge from the auriculotemporal nerve. Remember, auriculotemporal nerve was the nerve that has stolen the fibers of the lesser petrosal nerve. And where did the auriculotemporal nerve go? It went into the parotid gland. So the facial nerve also goes into the parotid gland. You see, it also goes into the parotid gland. Okay, so she is not happy, right? So what will she do? She will act like a suicide bomber, right? So she goes inside the parotid gland and she will explode herself. Okay, so she goes inside the parotid gland and she explodes herself. So she divides into 5 different pieces. Okay, 5 terminal branches, right? And the parotid gland is also divided into 2 parts, superficial lobe and deep lobe. So somebody asks you, parotid gland is divided into 2 lobes, superficial lobe and deep lobe. By which part? By which structure? Answer is facial nerve. So the facial nerve divides the parotid gland into 2 lobes, superficial lobe and deep lobe, and it itself divides into 5 terminal branches. Okay, so which are these 5 terminal branches? These 5 terminal branches over here are T, Z, B, M, C. Okay, so T for temporal, zygomatic, okay, buccal, marginal mandibular, and cervical. Okay, so these are the 5 terminal branches of the facial nerve. All right, now these 5 terminal branches of the facial nerve, they cover the face like this. Okay, they cover the face like this. So this is known as goose feet. This is known as goose feet, pes anserinus. Okay, this is known as goose feet or pes anserinus. They cover the face like this, right? So these are the branches of the facial nerve. All right, so this is the anatomy of branches of the facial nerve. Now remember, we studied the anatomy of the facial nerve. We studied that with the help of a dance number. So what was our dance number? Dance number was 343. So what do we mean by 343? 3 nuclei, 4 segments, and then third segment divided into 3 more segments. Okay, now the sequence for the branches of facial nerve is also like the next stanza of this choreography. Okay, next stanza of this dance. So the branches sequence is 3, 4, 3, 5. So what do I mean by 3, 4, 3, 5? We have the first genu has 3 branches. Okay, because now we are going to study the branches of facial nerve. You see, everywhere we will add first. Okay, that was the 0 stanza. This is the next, the first stanza. So we have first. Okay, so first genu, 3 branches. All right, which are those 3 branches? Number 1, GSPN, greater superficial petrosal nerve, the first nerve. And what is it carrying? It is carrying preganglionic parasympathetic fibers. Then we have the lesser petrosal and the external petrosal nerve. Right, now first genu, 3 branches. First branch, you see, the first branch GSPN, it supplies 4 places: lacrimal gland, nasal gland, minor salivary gland, taste in palate. Okay, lesser petrosal nerve, you see, it becomes a branch of the 9th cranial nerve. So I am not discussing it here. Okay, it is adopted by the 9th nerve. So forget about it in the facial nerve. It is a branch of 9th nerve. Right, so first genu, 3 branches. First branch, 4 parts it supplies, and then we have the third segment. It has 3 important or the first branches. Okay, the third segment, 3 important or first branches. First branch I told you was GSPN. First motor branch is nerve to stapedius. And the first embryonic branch, which is the branch to appear first embryologically, that is the chorda tympani. These are the 3 important branches in the third segment, that is the intratemporal segment. All of them are first. First branch, first motor branch, first embryonic branch. Okay, so 3, 4, see 3, 4, 3. And now we have to end the choreography. So we end it with the extra beat. So 3, 4, 3, 5. 5 terminal branches. Okay, so what are those 5 terminal branches? Temporal, zygomatic, buccal, marginal mandibular, and cervical. Right, so if you remember 3, 4, 3 and 3, 4, 3, 5, you can remember the anatomy of entire facial nerve and its branches. Right, now let us look at some diagrams. Now this is the diagram of the cerebellum. So we can see the brain, the cerebellum, and we can see the internal auditory meatus or the internal auditory canal. So we can see some structures entering into the IAC. So let's identify them. This is the cerebellum over here. We can, number 1, see the facial nerve. Okay, so that's the facial nerve going into the IAC. This is the vestibular nerve. Remember, we have vestibulocochlear nerve. So this is the vestibular part of the 8th nerve. All right, what else we can see? We can see the ICA, the anterior inferior cerebellar artery that rises from the basilar artery. So we can see the ICA, and then we can see from here coming out the labyrinthine artery, and we can also see the subarcuate artery. Right, so these are the structures which are visible over here, which are entering into the IAC. Okay, now this is the drilled part of IAC. So we can see that the IAC has been drilled open. The periosteum has still not been removed. Okay, so we are trying to drill the IAC and see what are the structures inside the IAC. So now the periosteum has been removed, right? In this diagram you can see that the IAC has been drilled partially, not completely, not till the meatal foramen, partially it has been drilled. So what all structures we are able to see? Let's revise them once again. We can see the facial nerve. You see, anteriorly we have the facial nerve, okay, and you can see this facial nerve, the nerve is joining, that is the nervus intermedius. Remember, the nervus intermedius is formed by joining of the two fibers, the fibers which come from the nucleus tractus solitarius and nucleus levatorius superioris. So you can see that there are two fibers which are coming and they together form the nervus intermedius, nerve of Risberg. And this nerve of Risberg goes and combines the facial nerve, as you can see over here, in the internal auditory canal, okay, in the intrameatal segment, so that you can see. All right, what else we can see? We can see the vestibular nerve. Now you can see that this vestibular nerve, you see, this was the vestibular nerve, and now you see it has divided into further two branches. Inside the IAC, you see it has divided into the superior vestibular nerve and inferior vestibular nerve, right? Okay, now we have drilled furthermore the IAC. So you see the IAC previously was drilled till here, now we can see it has drilled till here, right? So almost till the meatal foramen, not complete but almost till the meatal foramen, and now we are reflecting back the vestibular nerves. So what we can see over here, we can see the facial nerve. You have already identified the ICA, the anterior inferior cerebellar artery. You can see the labyrinthine artery over here. Okay, so interiorly you can see the facial nerve, right? Joining the facial nerve over here, this is the nervus intermedius, nerve of Risberg, that I just showed you previously. All right, so that is the nervus intermedius. Then we can see the vestibular nerve. In fact, that's the superior vestibular nerve. Just below that we have the inferior vestibular nerve over here. So you can see the inferior vestibular nerve, and you can also see, you know, that the superior vestibular nerve and the facial nerve, you see, the superior vestibular nerve and the facial nerve, they are going above this bony ridge. So you see this bony ridge, you can see that this bony ridge, above this bony ridge, the facial nerve and the superior vestibular nerve, they are going. So this is the superior vestibular nerve. This over here is the inferior vestibular nerve. So superior vestibular and facial nerve, they are going above this ridge of bone, that's known as transverse crest, right? Okay, the inferior vestibular nerve you can see is going below this transverse crest, right? And you can see over here that there is a nerve below the ridge, just below the facial nerve, there is a nerve over here, that is your cochlear nerve. So that is the cochlear part of the eighth nerve, right? Okay, so what we can do is, we can now, you can see the whole IAC is drilled. Now you see the whole IAC is drilled till the meatal foramen, complete till the meatal foramen, and now we have reflected back over here, this nerve over here, to show you what all structures are there. So which is this nerve? All right, let's go one by one. When we can see the ICA over here, that is the ICA, we have discussed that. Then that is the facial nerve. So now we know that is the facial nerve. This is the nervus intermedius. Okay, so that has joined the facial nerve. Both of them, they go anteriorly and above this ridge, the transverse crest, right? Okay, then this is the superior vestibular nerve. This is the inferior vestibular nerve. You can see the cochlear nerve. Cochlear nerve is going below the ridge. You see over here, it is going over here below the ridge, right? Okay, so that is the transverse crest. All right, so these structures, I hope that all these structures are visible to you now. Okay, now look over here, the facial nerve and the superior vestibular nerve, both of them, they are going above the ridge, right? Both are going above the ridge. Now, in between them, there is another ledge of bone. Now, this is the vertical crest. There is another ledge of bone, vertical crest. We call it as Bill's bar. Okay, so that is your meatal foramen, right? Now, let's look over here. Now, this is the view of the meatal foramen from inside the IAC. Okay, from inside the IAC, you see this meatal foramen. Now, you can, I'm trying to orient you. This is the anterior, posterior, superior and inferior. Okay, so I have tried to orient you to the anatomy of the meatal foramen. Now, in this meatal foramen, in the middle, we have a transverse crest. Okay, so as I just showed you, we have a transverse crest. Now, in the upper part, remember in the upper part, there is a vertical crest. We call it as Bill's bar. Now, this Bill's bar is after Dr. William House. Dr. William House, pet name or the house name was Bill. He was at home by his friends, called popularly as Bill. So after his name came the Bill's bar. Dr. William House is the father of neurootology. Okay, so he is the father of neurootology. This question has been asked in the MCQs. So William House, father of neurootology. His other name was Bill, and this Bill is the name given to this bar, Bill's bar. Okay, now what is the significance of this Bill's bar? You see, anterior to this Bill's bar, we have the facial nerve. So this Bill's bar is a very important surgical landmark for the facial nerve surgery. All right, now posterior to this Bill's bar, as I just showed you, is the superior vestibular nerve. Okay, now the lower part is not divided by any ridge, but we know that in the anterior part we have the cochlear nerve. In the posterior part, we have the inferior vestibular nerve. Okay, so in the anterior part, there is cochlear nerve. In the posterior part, we have the inferior vestibular nerve. So this is the anatomy of the meatal foramen. Okay, remember facial nerve is superior. So we can remember it as 7 up. Okay, so just remember 7 up. So 7 up is the cold drink. So 7 up. So facial nerve 7 is up. Okay, in the anterior to the Bill's bar. Okay, so upper part of the meatal foramen, anterior to the Bill's bar, we have the facial nerve. All right, so now that was the IAC and the meatal foramen. Now let's look over here. What do we see over here? You can over here identify that this is the sphenoid bone. Okay, now this blue bone over here is the palatine bone, and I'll be teaching you these bones when I come to the nose. So this is the lateral wall of the nose. But what I want to show you over here is that between the sphenoid bone and the palatine bone, we have a foramen over here. This foramen is known as sphenopalatine foramen. Between sphenoid bone and palatine bone, we have the sphenopalatine foramen. Now this is the view from inside the nasal cavity. We can also have this view from outside. Okay, so from outside you can again see the sphenopalatine foramen. So that foramen over here, this is the sphenopalatine foramen. Okay, so this over here is the sphenoid bone. All right, and over here this is the maxilla. So that is the maxilla. Now between the sphenoid and the maxilla, okay, you can see over here that this is the pterygoid process of the sphenoid bone, and between this pterygoid process of sphenoid bone and the maxilla, there is a fissure. This fissure is named as pterygomaxillary fissure. Okay, this is named as pterygomaxillary fissure. Now you see between the fissure and the sphenopalatine foramen, there is a space. As you can see in this diagram, there is a space. This space is known as pterygopalatine fossa. So remember, this is the fossa we just talked about some time back, the pterygopalatine fossa. In this pterygopalatine fossa, we have the pterygopalatine or sphenopalatine ganglion. The largest peripheral parasympathetic ganglion is over here, right? Okay, and once you come out of this pterygomaxillary fissure, if you come outside, then we have this space that is known as infratemporal fossa. So that's over here in the cheek, just in medial to this zygomatic arch. So you can see this zygomatic bone. Okay, so zygomatic bone, zygomatic process of temporal bone. Now just medial to this, we have the infratemporal fossa. Right? So I just wanted you to get accustomed to this anatomy because we have talked about the sphenopalatine ganglion, the largest peripheral parasympathetic ganglion. Okay. Now let's look in this diagram once again. You can see the sphenopalatine foramen, right? And if you come out, you can see the green color marked, we have the pterygomaxillary fissure. Now in between them, there is a space over here. Okay. So this space is known as pterygopalatine, or you can say sphenopalatine fossa, where we have the sphenopalatine ganglion, right? Okay, and outside that we have the infratemporal fossa, right? Remember, in the infratemporal fossa we have another ganglion, that is the otic ganglion. Okay, now let's revise what we just studied. Okay, so you see we have the otic ganglion, where? In the infratemporal fossa. All right, now what else do we see over here? You can see the lingual nerve coming from here. Lingual nerve, it is a branch of the mandibular nerve. All right, now you can also see the chorda tympani. So this chorda tympani nerve, it meets the lingual nerve, right? And together they start traveling, right? And where do they go? They go to the submandibular ganglion. After relaying in the submandibular ganglion, now the chorda tympani nerve, it supplies the submandibular gland and the sublingual gland, and it also gives taste to the anterior two-thirds of tongue. Okay, and the lingual nerve gives the remaining supply, the pain, the temperature, the touch sensation to the tongue, right? That is given by the lingual nerve. All right, now what else you see over here? You see in this otic ganglion, you can see that red dot. So that is the end of our nerve. Which nerve? The lesser petrosal nerve. It ends in the otic ganglion. Now the fibers of this lesser petrosal nerve are taken by the auriculotemporal nerve, and then this auriculotemporal nerve goes to the parotid gland, and it supplies the secretory supply to the parotid gland. Okay, so that is the anatomy of chorda tympani, the lingual nerve, the lesser petrosal nerve, the auriculotemporal nerve. Okay, right. Now let's come to this diagram. Let's revise all that we have just studied. Okay, so what we studied? We studied that the facial nerve starts from three nuclei. Which three nuclei? Nucleus tractus solitarius, nucleus livatorius superior, and motor nucleus in pons. Right, now from here you see the nucleus livatorius superioris and nucleus tractus solitarius, they give the fibers which becomes the nervus intermedius. This joins the facial nerve in the intrameatal segment, and now the facial nerve becomes a mixed nerve. Now you can see the ring over here. This ring is to mark the meatal foramen. Facial nerve crosses this meatal foramen, becomes the labyrinthine segment. What do we see over here? A sharp turn, that is the geniculate ganglion. What comes out of geniculate ganglion? Three branches. Okay, which three branches? GSPN, external petrosal, and lesser petrosal. Okay, look at the GSPN. The GSPN, it combines with the branch coming from the tympanic plexus. Which branch? Deep petrosal nerve, and together they form the Vidian nerve, nerve of pterygoid canal. This goes into the pterygopalatine fossa, where there is pterygopalatine ganglion, right? And thereafter they supply four places like crimal gland, nasal gland, minor salivary glands, and taste in palate, right? Okay, then we have this nerve. What is the second nerve? We have to remember the nerve to stapedius, the first motor branch of facial nerve. You can see the yellow color is the motor fibers, the pink color are the sensory and secretomotor fibers. So this is the first branch of the facial nerve, nerve to stapedius. Okay, right? And then we have the chorda tympani, the first embryonic branch. This chorda tympani also comes out of the middle ear into the infratemporal fossa, and there it combines with lingual nerve, and thereafter it supplies taste and submandibular and sublingual salivary glands. Okay, facial nerve gives some more motor supplies, and then it goes out of the stylomastoid foramen, and then it forms five terminal branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. Okay, so they supply the face, right? So this is the anatomy of the facial nerve and its branches that we have just studied, right? Okay, let's go and study the question. A patient underwent removal of submandibular gland and lingual nerve was damaged during surgery. So they have mentioned that the lingual nerve was damaged. Which of the following is not correct? You see, this question was asked recently in the FMG August 2020 exam. Rate of sublingual secretions is reduced. You see, when the lingual nerve is damaged, that means the chorda tympani fibers are also damaged. Lingual nerve is carrying the fifth nerve fibers as well as the chorda tympani fibers. So rate of sublingual secretions is reduced. That's a correct statement. All right, we have to find which is not correct. See over here, not correct. Anterior two-third taste sensation is lost. That is also correct. Sensation in the floor of mouth is lost. Yes, anterior two-third, floor of mouth and the tongue, they're supplied by the lingual nerve, so that will also be lost. Tongue deviated to side. Tongue muscles, they are supplied by the hypoglossal nerve. Hypoglossal nerve is not damaged. Okay, so now this is not a correct option and therefore this is our answer. You see, we have to find the option which is not correct. All right, let's look in this photograph. In this photograph, you can see the submandibular space. The submandibular space is divided by mylohyoid into two parts, the sublingual space and the submylohyoid space. Now, in the submylohyoid space, you can see this submandibular gland. So, if I am doing the surgery of this submandibular gland, let's look at another diagram. So, what do we see? Which nerves are there? We can see the hypoglossal nerve and we can see the lingual nerve. Any of these nerves can be damaged. So the question specifically mentioned that the lingual nerve is damaged. Okay, hypoglossal nerve is not damaged. So therefore, the tongue nerve supply is normal. So tongue will not be deviated to the other side. Right? So this question, tongue deviated to side, is a wrong option and therefore this is our answer to this question. All right? Okay. Now, before we finish this topic, let us discuss the landmarks of the facial nerve in the parotid surgery. So, this question is also asked. We know in the extratemporal segment, the facial nerve goes inside the parotid gland. So, when we have to do the dissection of parotid gland, we have to identify and save the facial nerve. So, what are the landmarks? Okay, the number one landmark, you can see over here the facial nerve, and just near to facial nerve, the number one landmark that is used is the tragal pointer. So this is the cartilaginous pointer, the tragal cartilage. You can see the tip of the tragal cartilage. Now the facial nerve lies 1 to 1.5 centimeter, 1 to 1.5 centimeter, okay, deep and anterior to the tragal pointer. Okay, deep and anterior, right? So to the tragal pointer, that's the first landmark. But remember, it's a soft tissue landmark. So that's why I am giving a variability 1 to 1.5 centimeter. Soft tissue landmarks, they can also be moved due to retraction. When you're doing surgery, you're retracting. So they may also be moved. It's a soft tissue landmark. All right. So not a very reliable landmark. Commonly used, but not a reliable landmark. What else we can use? We can use a bony landmark. Very reliable landmark, styloid process. The facial nerve always lies lateral to the styloid process. Okay, another landmark that we use over here, you see there are two muscles which are coming from the mastoid process. Which two muscles? On the lateral aspect, we have the sternocleidomastoid muscle, SCM muscle. From the medial aspect, we have the posterior belly of digastric. So that serves as our landmark. Facial nerve is superior, anterior superior to the posterior belly of digastric muscle. Right? So these are three landmarks. We use some more landmarks. Number 4, that's the most reliable landmark for us. That is the tympanomastoid suture. Okay. So you see this is the facial nerve, and this over here, the facial nerve comes out of the stylomastoid foramen, and this is approximately 6 to 8 millimeter anterior to the tympanomastoid suture. Okay, this is a bony landmark, it's a fixed landmark. That's why I'm saying it is one of the most reliable landmarks that we have to identify the facial nerve. Okay, so we can see this facial nerve, it is coming and then it divides into the temporal division, the cervical division, inside the parotid gland, but this is the landmark that we use. Finally, sometimes if you are confused, there is a tumor over here, you are not able to identify any of these landmarks, we can also do one thing. We can do the surgery in the reverse way. Reverse way means we can first identify these branches of the facial nerve. Okay, and you can do a reverse dissection of the parotid gland to identify the main stem of the facial nerve. Okay, you can see these facial nerves, and as I told you that this spread of these branches, this is known as pes anserinus. Okay, goose feet, I have already described for you. So you can see over here these branches, they are spread on the face. like a goose feet. All right. Okay. Question asked in the exam, recently asked, NEET PG January 2020. Not a landmark of facial nerve identification in parotid surgery. So we can use the peripheral branches. We can use posterior belly of digastric. We use the tragal pointer, but we don't use the inferior belly of omohyoid. We use the posterior belly of digastric. Okay, not the inferior belly of omohyoid. Okay, so that is our answer. Question was not a landmark. So this was the anatomy of the facial nerve and its branches. Let us discuss the tests of facial nerve. Okay, so the first part that we are going to discuss are the topodiagnostic tests of facial nerve. So what are these topodiagnostic tests? Topodiagnostic tests are those diagnostic tests which help us identify the topological position, the location of the injury to the facial nerve. Okay, so if there is any injury to the facial nerve, we can identify that place by these topodiagnostic tests of facial nerve. All right, so which is the first topodiagnostic test? The first topodiagnostic test is the Schirmer's test, also known as tear test or lacrimation test. Okay, now what do we do in this test? We put two blotting papers in the inferior fornix of the eye, and then we keep them for 5 minutes and we measure the wetting or the lacrimation. Because of that, there is wetting in the blotting papers. Okay, so this is known as Schirmer's test. Now, how do we analyze this test? Now, let's say we have a patient. Patient has right side facial palsy. Okay, so the patient has right side facial palsy. All right, now if we do this Schirmer's test, okay, if we do this Schirmer's test and the lacrimation of the right side is equal to lacrimation of the left side. Okay, so if the right side lacrimation is equal to the left side lacrimation in a patient who is having right side facial palsy, you remember the lacrimation is brought by the GSP and greater superficial petrosal nerve. So if there is no difference, okay, no difference means we call this Schirmer's test as negative. Okay, negative test over here means normal. All right, normally it should be negative. Normally there should not be difference in right side and left side lacrimation. So if the test is negative, that means normal. That means the facial nerve, okay, the seventh nerve, the facial nerve is normal till first genu. Okay, remember at the first genu the GSPN comes out. So that means the facial nerve is normal till first genu. There is no damage to the facial nerve till the first genu. The damage must be after that. Okay, now if the Schirmer's test is positive, positive means patient has come with right side facial palsy and the right side lacrimation has gone down. You see, the right side lacrimation has decreased. So that means there is a positive difference between right side and left side. So the test is positive, there is a difference. Okay, now the positive over here is abnormal. Okay, the positive is abnormal. That means the injury has happened at first genu, okay, or it is above first genu. So at or above the first genu, we have the injury if the Schirmer's test is positive. Okay, so that was your Schirmer's test or tear test or lacrimation test. The second test we come to is the stapedial reflex test, also known as acoustic reflex. So we have already studied this test. Okay, so now what is the stapedial reflex? Stapedial reflex, whenever you give a loud sound stimulus, the stapedius muscle, it contracts. It pulls the stapes back, fixes the stapes, stapes is not able to vibrate. Okay, that is your stapedial reflex. How do we check it? We check it with the help of impedance audiometry. Right, now stapedial reflex, okay, you see what happens now. You give a loud sound stimulus, the stapedius contracts. Okay, stapedius is supplied by the seventh nerve. That's a normal reflex. Okay, so normally, you see, normally the stapedial reflex is positive. Normally the stapedial reflex is positive. So positive is normal. If the stapedial reflex is positive, it's a protective reflex. So it has to be present. It is present, it is positive. That means it's a normal response. That means the facial nerve is normal till second genu. Remember, the nerve to stapedius comes out immediately after the second genu. Okay. Now, if this reflex is absent, you see, if this reflex is absent, okay, that means the test is negative. Now, negative over here is abnormal. Okay, negative is now abnormal. That means the injury has taken place at or above second genu. Okay, at or above second genu. Right? Okay, that is the place for injury. Now, the next test is the taste test. Okay, the taste is measured with this electrogustometry. So, we give small voltage current and we check whether the taste buds they are working or not. Okay, so whether the patient has that taste sensation or not. Now, this taste is supplied by chorda tympani nerve. Taste in the anterior 2/3 of tongue supplied by chorda tympani nerve. Okay, now remember this test is positive. Usually in a normal person, this test is positive. A normal person feels the taste. Okay, so that means if it is positive, it means it is normal. That means the facial nerve is normal till, you see, the chorda tympani nerve comes just above the stylomastoid foramen. So that means the facial nerve is normal till stylomastoid foramen. Okay, stylomastoid foramen. All right, let's say the taste is gone. Let's say the taste is gone. This test is negative. Now the negative over here is abnormal. Okay, the negative over here is abnormal. Now that means the facial nerve injury has happened where? Above the stylomastoid foramen. Okay, now you see I have not used the word at. In the previous two, in the tear test, in the stapedial reflex test, I use the word at or above some place. Like in the tear test I used, look over here, at or above first genu, because the nerve was arising from the first genu. Okay, in the stapedial reflex again I use the word at or above second genu, because the nerve was arising just after the second genu. Here the nerve is arising just before the stylomastoid foramen. So if there is an injury at stylomastoid foramen, chorda tympani will not be damaged. So if there is an injury to chorda tympani, if the taste is gone, that means injury to the facial nerve has happened above the stylomastoid foramen, not at. This is an important point. At stylomastoid, taste will not be affected. Above stylomastoid, taste will be affected. Right? So remember, I have not used the word at over here. Okay, and finally we have submandibular salivary flow rate. Submandibular gland is again supplied by chorda tympani. Okay, so once again this test is dependent upon chorda tympani. Now what you do is you put two small cannulas in the submandibular duct on both the sides and you collect the saliva for 30 minutes. So this is again a comparative test. Just like the Shermer's test, this is also a comparative test of right side with left side. And in a comparative test, both the sides have to be equal. Okay, so both the sides have to be normal. For both the sides to be normal, the test, there should not be any difference. Okay, so that means if it is negative, there is no difference, that means the test is normal. Okay, so submandibular salivary flow rate, both side flow rate, there is no difference, test is normal. That means the facial nerve is normal till stylomastoid foramen. Okay, right. Now let's say there is a difference in salivary flow rate. The patient came with right side palsy and now on the right side the salivary flow rate has decreased. So the test is now positive, the difference is present. Okay, so difference present, the test is positive. That means this is abnormal. Okay, once again, the injury has taken place above stylomastoid foramen. Again, it is dependent upon chorda tympani, so I am not using the word at, I am using the word above stylomastoid foramen. Only above, not at. Okay, so these were the 4 topodiagnostic tests of facial nerve. Which 4 tests we have discussed? Shermer's test, stapedial reflex test, taste test, and submandibular salivary flow rate. Okay, let's do a question. Before we go ahead, let's do a question. Let's say we have a patient of road traffic accident, RTA. Okay, a 30-year-old patient, RTA patient, comes to you with right facial palsy. Okay, right facial palsy. Now on examination, Shermer's test, taste test, stapedial reflex test. Okay, all these 3 tests were negative. Where is the site of injury? Where is the site of injury? Okay, I'll give you the options: segment 3A, segment 3B, segment 3C, and segment 4. Okay, what is the site of injury? Alright, let's solve this question. Now, first see, the Shermer's test is negative. Okay, so Shermer's test is negative. Negative Shermer's test means there is no difference of right side with left side lacrimation, and negative Shermer's test is normal. That means the facial nerve is normal till first genu. Right? Now the second test in our sequence was, forget the question, in our sequence the second test was stapedial reflex test. Okay, the second test was stapedial reflex test. Now stapedial reflex test is negative. Stapedial reflex is usually positive. So if this test is negative, now this is abnormal. Okay, that means the injury has taken place at or above second genu. Okay, so you see, till first genu facial nerve was normal. Injury has taken place at or above second genu. What is between first genu and second genu? We have the tympanic segment, the segment 3B. So we have our answer over here. Okay, so answer is segment 3B. Now which test is left? The taste test. Now we didn't need the taste test to solve this question. That was given just to confuse you. Okay, now let's see over here. Taste is negative. You see, taste is negative. Taste negative means taste is absent, and that is abnormal. Okay, that is abnormal. Now taste absent means the injury has taken place above the stylomastoid foramen. Okay, injury has taken place above stylomastoid foramen. It does not say which segment. Don't get confused. Okay, it just says it is above the stylomastoid foramen. It can be anywhere. In the whole pathway, it can be anywhere just above the stylomastoid foramen. That means it can be in segment 1, it can be segment 2, segment 3A, segment 3B, segment 3C. Anywhere but above stylomastoid foramen. Okay, if we are looking at only the taste test. But we are looking at the remaining tests also. So when we look at the remaining test, we know Shermer's test, it was negative. So it cannot be the injury above the first genu. Alright. So anywhere above the segment, anywhere above the stylomastoid foramen. So we know it can be segment 3B or it can be segment 3C. We already know stapedial reflex test is negative. That means the injury is above the second genu, it is in segment 3B. So anywhere the facial nerve is damaged, the remaining following test will be affected. Just remember that. Don't get confused. Taste test is negative. It has to be segment 3C. Many students make this mistake. Okay. It is above the stylomastoid foramen. It can be 3C. It can be 3B. Okay. We have to look at the remaining tests to come to the answer. right? Okay, so this is how we solve these question. Test which is negative, whether it is normal or abnormal, that's what you have to remember. Easy way, if it's a comparison test of right side with left side, then negative means normal, because there is no difference, right? Okay, so these were the topodiagnostic tests of facial nerve. Let's come to the electrophysiological testing of facial nerve. Okay, to understand the electrophysiological testing, what do I mean by electrophysiological testing? Let's study the structure of a neuron. You see, this is the neuron, it has a cell body. Okay, now you can see the nucleus in the cell body, you can see the dendrites. Then it has an axon. Okay, this axon you see is covered by the myelin sheath. Okay, this myelin sheath is formed by Schwann cells, and in between the Schwann cells you can see the nodes of Ranvier, and these are the axon terminals. Okay, now you see these myelin sheath, it covers this whole axon. This neuron, this acts like a electrical wire. If you give a current, it will take the current. It's like an insulated wire. Okay, so if you give a current, you can check for the response of the current at a distance. All right, now if I cut this neuron, what will happen? If I cut this neuron, what will happen? If I cut this axon, what will happen? You see, within 5 to 60 minutes, the calcium is released. Okay, these enzymes are released, the calpain enzymes are released. And what happens to these cut ends? Slowly and slowly, if you see, within 72 hours, what do you see? The distal part of the neuron, of the axon, that is all gone. Okay, this distal part you see, this is all gone. It is eaten up by the astrocytes, by the macrophages. This is known as Wallerian degeneration. This Wallerian degeneration takes place in approximately 72 hours. Okay, it takes place in 72 hours. So, if I want to find out that a nerve is injured, what can I do? Suppose this nerve, one nerve is injured in the hand. So, what can I do? I give a stimulus proximal to the nerve and I check for response distal to the injury. Okay, so proximal to the nerve injury, I give an electrical current, and distal to the nerve injury, I check for response. So I give a current over here. All right, now one nerve has thousands of neurons. If only some of the neurons are cut, I will have partial response. If all the neurons are cut, there will be no response. Let's say these neurons are not cut. They are being pressed by a tumor. So the nerve is stretched. So what will I have? I give electrical stimulus over here. I'll check for a response. The response comes, but after some delay. After some delay in time. That's because the nerve is stretched. So I can check for the response intensity. I can check for the delay in the response, the time taken for the response, and by that I can find out whether the nerve is injured, it is stretched, it is damaged. So all that can be done with the help of electrophysiological testing. This is electrophysiological testing. The nerve acts as a electrical wire, right? Okay, so that is for any nerve in the body, you can do the electrophysiological nerve testing. What is so special about the facial nerve? The special thing about the facial nerve is the facial nerve travels in a bony canal known as fallopian canal. Most of the injury happens in the bony canal, but you cannot give current proximal to the canal because that means the brain. You cannot give a current proximal to the injury. So what will you do? What will you do? Okay, you have to wait for 72 hours. Why? Because in 72 hours, this Wallerian degeneration will take place. Okay, so suppose, you give a current over here, you get the response over here, you check the response over here. This you can do in a normal nerve. But in the facial nerve, you cannot give the electrical stimulus proximal to injury. Now, you can give a stimulus over here in facial nerve, you check for response here. This is done after 72 hours. So, after 72 hours, if you do that, there is no electrical wire. All right, there is no neuron. So, that means now you will not get any response. before 72 hours if you do, you see, before 72 hours if you do, you will still get some response, okay. So you cannot do that in the facial nerve because you are giving stimulus after the injury. You give at the stylomastoid foramen, okay. So you give after the injury and you can check for response. So facial nerve electrophysiological nerve testing is done after 72 hours, okay. So what is the benefit? What is the benefit? The benefit of this test, see, these are not your topo diagnostic test. You see, we don't know where the injury is. Injury has happened before the nerve injury, before the nerve stimulus, okay. Injury has happened somewhere over here. You are not checking the topological location. What are you checking? You are checking in a nerve how many neurons are cut, okay. So what are you checking? You are trying to find out the prognosis of this patient. So the topo diagnostic test were to find out the location of the injury. The electrophysiological tests, these are prognostic tests, okay. These are prognostic tests. They tell you the prognosis of the injury, right? Okay. So let us discuss these electrophysiological testing. So we'll discuss a few tests. Now it depends how you are giving the stimulus and how you are checking the response. So based upon that, we have a few tests, okay. Number one, you can see over here, this is the electrophysiological testing being done. You give a stimulus and you check for response. This response can be checked by different ways. You can put the electrodes on the skin and you can check for the nerve response, or you can put the electrodes inside, the pin electrodes inside the face, inside the muscle, and you can check the response there. So based upon that, we have a few different tests. Now the number one test is the nerve excitability test, okay. It is the nerve excitability test. Now what is done in this? You give a electrical stimulus, okay. So you give a current that varies between 2.4 to 16.2 milliamperes. So you give a very, very small voltage current, okay. Minimal possible electrical current is given, minimal possible. You just trying to see that how much minimum current you can give and still create a response, still get some response in the muscle movement, okay. So this is the minimum possible, minimum required current, okay. Minimum required current to create a response. You compare of right side with the left side, okay. And the result is significant if the difference is more than 3.5 milliamperes, okay. So that means on one side you require a very low like 2.4 milliamperes, on this side you require 8 or 10 milliamperes, okay. So that means this side is having a problem. You are needing more current to just make a muscle twitch, okay. So that is your nerve excitability test. This is the minimum current required. Now after this test we have the maximal stimulation test, MST. So what is in this? We check how much current is required that can produce the maximum twitch. So we want to see the maximum contraction, and we want to see for this maximum contraction how much stimulus is required, okay. So that is your maximal stimulation test. Remember, both the NET and the MST, they can be done after 72 hours, right? Okay. The next is the electroneuronography. Neuronography, neuron. So you are not checking the muscle, okay. Electroneuronography, it is also known as evoked electromyography, okay. Evoked electromyography. So it is also known as EEMG, okay. Electromyography. So you are checking the potential, but it's a evoked after giving a stimulus, okay. Electromyography. So what you are checking is that you are checking the compound action potential inside the muscle, okay, after giving a stimulus. That is very important. It's a evoked. You give a stimulus and then you check the action potential inside the muscle, the compound action potential inside the muscle, all right. Now this is useful from 3rd day to the 14th day of onset of palsy. Okay, so this test is most useful between the 3rd to the 14th day. After 14th day, you see what happens is that some interfaces, they start interfering with the muscle if there is a regeneration or anything. So now this test after 14th day becomes less useful clinically. Okay, so from 3rd day to 14th day, we can use the electroneuronography. Okay, and it will tell you if there is a lot of loss over here, more than 90%, then this is the best guideline that you have to do a facial nerve decompression if there is an injury, if the bone is pressing the facial nerve. So you can do that by doing this electroneuronography, right? Okay, then we come to electromyography. Now electromyography, you see, the previous one was ENOG or evoked electromyography. You had given a stimulus. Now electromyography, there is no stimulus. Okay, now this test, there is no stimulus. So what is this? Okay, this is the spontaneous activity of the facial muscles. Okay, spontaneous activity of the facial muscles. Now you see what happens. What happens? There is no nerve stimulus. So this spontaneous activity will start going down. Okay, but the facial muscle, they will take time to undergo atrophy. So it will take approximately 3 weeks, 21 days. It will take almost 21 days for this activity to go down. Okay, and after that, if there is some recovery, then some activity may restart. Okay, so you know, this is a very good test after 3 weeks, right? So it takes almost 14 to 21 days, as I was telling you, for these fibrillation potentials. So these fibrillation potentials, they develop after 14 to 21 days when the nerve stimulus is gone. Okay, and this is the most reliable test that tells us that there is a denervation which has taken place. The nerve has undergone atrophy, the distal part of the nerve. Therefore, the muscle has also undergone atrophy. So this is the most reliable after 21 days. If there is a re-innervation, then that also we come to know with the help of electromyography, right? Okay, so this alerts us that there is some, you know, sometimes you don't see any recovery. You don't see any recovery and you are planning for surgery. But this test, if it is positive, it is showing recovery, it is showing some waves. So that means it will alert us that there is some subclinical evidence of early regeneration. So we can wait and avoid the surgery. So that is the electromyography, right? So these were the tests which are done to check the facial nerve functions. Let us now discuss the disorders of facial nerve. So if we have understood the anatomy of facial nerve and its branches, if we have understood the tests of the facial nerve, the topodiagnostic test, the electrophysiological nerve testing, then it will be very easy for you to understand the disorders of the facial nerve. Okay. Now, before we start with the disorders of the facial nerve, let's talk about the UMN, that is upper motor neuron lesion, and the lower motor neuron lesion. Okay, upper motor neuron and lower motor neuron lesion, these we are talking for the facial nerve, right? Okay, so let's see over here, this is the facial motor neuron. Now, this is the facial motor neuron, we know it is in the pons, brainstem. So now any injury to the facial nerve below this motor neuron, we know from this motor neuron starts the facial nerve. So any injury that is over here below the motor neuron, what will happen? That's known as lower motor neuron lesion. Okay, now a lower motor neuron lesion, what will happen? You see that one half of the face, you see over here, one half of the face, it undergoes palsy. Same side. The side, there is a lesion, on the same side, there will be a facial palsy. So, lower motor neuron lesion is always ipsilateral. Okay, it is ipsilateral and it is complete. You see over here, it is a complete one half of facial palsy. Okay, so one side of the face, complete palsy. Okay, upper part, lower part, the whole is palsied on that side. Okay, it's a ipsilateral complete facial palsy. So when I say complete means this part, this half of the face is undergone complete palsy. That's a lower motor neuron lesion. Okay, now let's go to the upper motor neuron region. Now you see that this facial motor neuron, this is under the control of the motor cortex. Okay, it's under control of the motor cortex. Now let's look at the, so let's say this is the right side, let's look at the right motor cortex. Okay, so you see this is the right side, this is the right side motor nucleus. Okay, and this is the left side motor nucleus over here. Okay, now we have right and left motor cortex also. So what do you see? You see the right motor cortex is giving supply to the contralateral motor nucleus. Okay, it is giving supply to the contralateral motor nucleus, but some supply is also being given to the upper part of the ipsilateral motor nucleus. You see, this is also bringing supply to the upper part of the motor nucleus. Upper part means this part which is supplying the upper part of the face. Okay, it is also being supplied by the same side. Okay, now what does that mean? What does that mean? Let's try to understand. Suppose there is a right upper motor neuron lesion. Okay, now this is above the motor nuclei, so we call this right side upper motor neuron lesion. So let's say there is a right upper motor neuron lesion. Now what happens? Now what all fibers are gone? You see, this fiber is gone. To the same side fiber is gone. Does it make a difference? No. Why? Because the fibers which are coming from the left side, left motor neuron, they supply the whole motor neuron of the right side. So no problem. What else is gone? These fibers are gone. Okay. So when these fibers are gone, you see the upper part, this still being supplied. Why? Because it is getting fibers from the same side motor cortex also. But the lower part is gone. The lower part is always supplied by the contralateral side only. So now this patient will not have the supply in the lower half of the face. Okay, so we have a lesion over here. Okay, the palsy is over here. So this is a contralateral, opposite side. Contralateral lower half facial palsy. Okay, so in case of upper motor neuron lesion, you see, in case of upper motor neuron lesion, patient will have contralateral lower half facial palsy. In case of lower motor neuron lesion, patient will have, you can notice over here, patient will have ipsilateral complete half, complete of that side, complete facial palsy. Okay, so this is the difference between upper motor neuron and lower motor neuron lesions of facial nerve. Alright, now let's come to Bell's palsy. Now you see, Bell's palsy, this is the most common cause of facial palsy. Okay, what is Bell's palsy? Bell's palsy is idiopathic ipsilateral lower motor neuron facial palsy. Okay, idiopathic ipsilateral lower motor neuron. These three terms define Bell's palsy. What do I mean by idiopathic? Idiopathic means no known cause. Okay, no known cause. Ipsilateral lower motor neuron. We know that lower motor neuron palsy is always ipsilateral. Okay, so there is no doubt about that. Okay, idiopathic. Idiopathic means no known cause. But nowadays, you know, a lot of causes have been defined for this Bell's palsy. A lot of hypotheses have been given. The most forerunning hypothesis is the viral infection. Okay, so it is a viral infection. Because of the viral infection, now the facial nerve undergoes inflammation, and because of the inflammation, there is a swelling. Okay, there is a swelling. So because of this swelling, what happens? You see the facial nerve swells, it expands, but the facial nerve is in the fallopian canal, the bony canal. Now this canal does not expand. So when this fallopian canal does not expand, whereas the nerve expands, so what happens? The facial nerve, it gets compressed in its own bony canal. Okay, there is a compression, and because of that we have Bell's palsy. Okay, now which part of the facial nerve will be compressed? That is the labyrinthine segment. Why? Because it is the narrowest segment. So this part undergoes compression. Okay, that is the number one, the viral infection. Number two is the hypersensitivity. This hypersensitivity theory or the allergic theory, it says that the antibodies which are produced, these antibodies, they cause a hypersensitivity or the allergic reaction inside the facial nerve. Okay, number three is the autoimmune theory. That means the antibodies, they attack the facial nerve. Now, again these theories, they again dwell on the same thing, that there is a swelling of facial nerve and the facial nerve gets compressed in the fallopian canal, in its own bony canal. So all these theories, okay, they all dwell on one thing, that there is a swelling of the facial nerve that leads to the compression in its own bony canal. Okay, that leads to a lower motor neuron facial palsy. Okay, so if you look in this patient, you will have the loss of forehead and the brow movements, you will have the drooping of eyelids, the inability to close the eyes, the loss of nasolabial fold, drooping of the lower lips. So it's a complete half facial palsy, right? One half of the face is gone. You can see that the lip, you know, it is deviated to the other side. Okay, so this is our Bell's palsy. Right? Disease that is similar to Bell's palsy is known as herpes zoster oticus or Ramsay-Hunt syndrome. Okay. Now this herpes zoster oticus or Ramsay-Hunt syndrome is a proven herpes zoster infection. Okay. This is a proven herpes zoster infection. Now what is seen in this? Again we have lower motor neuron facial palsy. Okay, now this lower motor neuron facial palsy is of course going to be ipsilateral. The side there is a problem, the same side there is a palsy, that we know is common with, that is what is obvious with lower motor neuron palsy. Plus number two, there is vesicular rash. Vesicles means the fluid filled lesions. There is vesicular rash in external ear. And number three, patient also have pain. Because of this, patient has pain, patient has otalgia. Okay, so Ramsay-Hunt syndrome or herpes zoster oticus is triad of these three things: lower motor neuron facial palsy, vesicular rash in external ear, and otalgia, ear pain. Okay, now this vesicular rash has vesicles, fluid filled lesions. Okay, you can take the fluid from these vesicles, you can send it for PCR, and in that you can demonstrate the presence of virus. Okay, so this is a proven herpes infection. Okay, how is the Ramsay-Hunt syndrome different from Bell's palsy? Bell's palsy, again we are saying that most common cause is the viral infection. Okay, now how is this different from Bell's palsy? It is different from Bell's palsy because the Bell's palsy prognosis, okay, it has a good prognosis. As compared to Ramsay-Hunt syndrome, it has a good prognosis. Now what do I mean by good prognosis? 70% patient, they show full recovery. Okay, and 15% patient, they show partial recovery. So that means 85% patients recover from Bell's palsy without any treatment. Okay, 85% patient, they will recover on their own without any treatment. Ramsay-Hunt syndrome, the recovery rate is approximately 50%. That is also many times partial. Okay, and then Ramsay-Hunt syndrome, the virus may involve the other nerves. Alright, it may spread to the 8th nerve. So patient will have vertigo, tinnitus, sensorineural hearing loss. it may spread to the fifth nerve, patient may have trigeminal neuralgia. So Ramsay-Hunt syndrome, the virus can spread to other cranial nerves and can cause more problems, right? Okay, now that was the difference between Bell's palsy and Ramsay-Hunt syndrome. All right, what is the treatment for Bell's palsy? This question is asked in the exam. My first question is, why do we need treatment? 85% patients, you see, they are recovering on their own. Do you need treatment? Yes, we need treatment. Why? Why? Because we want to increase the recovery rate. So 85% patients were recovering. We want 99 or 100% patients to recover. So we want to increase the recovery rate. Number two, we want to decrease the recovery time taken to recover. So for these things, we need treatment. Okay, so what treatment will you give? You see the main problem. What is the main problem with the patient? The main problem is that the nerve is swollen. There is a swelling. You want to decrease the swelling. Okay, what will you give? You will give anti-inflammatory. Which is the best anti-inflammatory? Now the best anti-inflammatory is the corticosteroids. Steroidal anti-inflammatory, the best anti-inflammatory. Okay, you give corticosteroid. Which corticosteroid you give? Okay, let's say you give prednisolone. Now, what is the dose of prednisolone that you give? You give 1 milligram per kilogram body weight per day. Okay, 1 milligram per kilogram body weight per day. So, let's say there is a 60 kilogram person, you will give 60 milligrams. For how many days you will give? You give it for 7 days, right? So number one, you give corticosteroid. Anything else that you can give? Yes, you can give the antiviral. Remember, the most prominent theory is the viral theory. So you can also give antiviral. So which antiviral you give? You give acyclovir. Okay. Now, what is the dose of acyclovir? Somebody asked you, this is a pharma question. Adult dose of acyclovir is 800 milligrams 5 times a day for 5 days. That is the adult dose of acyclovir. You give it for 5 days only. Nowadays, we have some other antivirals also that you can give. But acyclovir dose is many times asked. So it is 800 milligrams 5 times a day for 5 days. Now remember, the utility of giving antiviral is only if it is given within 72 hours. Okay, within 72 hours of onset of facial palsy. If you give after that, no use, because the antibodies have already formed in the body. Okay, so antiviral drug acyclovir, if it has to be given, it has to be given within 72 hours of onset of facial palsy. Okay, anything else that we can give? Yes, we can give over here. You see, the patient is having one side complete facial palsy, so he is not able to close the eye. Right? What else? What else? You see, the GSPN is gone because the palsy is in the labyrinthine segment before the first genu. So GSPN is gone. GSPN is gone means lacrimation is gone. Lacrimation is gone means the eye is a dry eye. Now the eye is not able to close. Blink reflex is gone. The cornea is dry. What can happen? There can be corneal ulceration. You don't want that. If there is a corneal ulceration, patient can go blind. Okay, so what you have to do? You have to advise the patient eye care. Okay, eye protection. So how will you protect the eye? How will you protect the eye? You can protect the eye by different ways. Number one, you ask the patient to use the artificial teardrops. Okay, so the patient uses artificial teardrops. Okay, what else? The patient can use goggles. Okay, now whenever the patient goes to sunlight or the patient goes in a windy environment, so patient can wear the goggles that will prevent the drying. Now what else can the patient do? The patient can pad the eye. He can put some tape over here and close the eye so that the eye is closed in the night time. There is no drying. All right. So the patient can use different methods to close the eye and protect the eye. What else can the patient do? The patient will also need to do some physiotherapy. Okay, physiotherapy to maintain the tone of the facial muscles. Like he can blow a balloon, right? If he tries to blow a balloon or he tries to chew a chewing gum, that will keep the buccinator and the remaining muscles in good tone, right? So you can use these four methods. So four methods: number one, corticosteroids; number two, antiviral; number three, eye protection; number four, physiotherapy. Okay, so the treatment of Bell's palsy, you give all this medical treatment for how many days? You give this medical treatment for 7 days. So let's say the patient comes to you after 7 days. Okay, after 7 days, there is no recovery. If there is recovery, then it is very good. Okay, then you are happy, the patient is happy. But if there is no recovery, what will you do now? Now you will repeat the same medication for next 7 days. Okay, sometimes it takes time for the facial nerve to recover. So you repeat it for next 7 days. Only thing is acyclovir course is complete. So that is all right. Okay, no need to repeat it. Okay, stop acyclovir. Anyways, you gave acyclovir for only 5 days. So acyclovir dose is complete, that you can stop. Remaining you repeat for next 7 days. Remember, the eye protection and physiotherapy, it continues till complete recovery. You will never stop it till there is complete recovery. Which two things? Eye protection and facial massage, the physiotherapy. Okay, right. Now let's say patient comes to you after 14 days of facial palsy. So in these 14 days of facial palsy, patient has taken steroids. Still there is no improvement. Now what will you do after 14 days of steroid treatment? You see, you cannot give steroids everlasting. You have to stop the steroids somewhere. 14 days of 1 milligram per kilogram body weight of prednisolone, that makes it now an immunosuppressive dose. From anti-inflammatory, now it has converted to immunosuppressive dose after 14 days. So now you stop it. Okay, but you don't stop it like that, you taper it away. So steroids, you taper away the steroids. Okay, so after 14 days you have to taper away the steroids. But what will you do? The patient is not having recovery. What will you do? Now you will do electrophysiological nerve testing. You see, you do electrophysiological nerve testing. Okay, remember, 3 days to 14 day you can do the ENOC test. Okay, from 14 to 21st day, if after 14 days then ENOC becomes useless, then you can do electromyography, EMG. It is useful from 14 day or best from 21 days. So you can use these two tests and you can decide. Now, if the electrophysiological test gives you a poor prognosis, okay, so if the electrophysiological test, shows you that the prognosis is poor, then you will go for surgical decompression. You will decompress the facial nerve. Okay, which segment you have to decompress? You have to decompress the labyrinthine segment. Okay, you have to decompress this labyrinthine segment. And for decompressing the labyrinthine segment, you see the facial nerve is compressed in the labyrinthine segment, but the external ear, the middle ear, the inner ear, they are all fine. You don't want to damage that. So what will you do? You will go through the middle cranial fossa and you will directly reach the labyrinthine segment. This is known as middle cranial fossa approach to decompress the labyrinthine segment of facial nerve. Now, if the electrophysiological testing, it shows that there is a good prognosis, now you have tapered off the steroids. Now what you can do is, you can give the patient electrophysiotherapy. Now what is electrophysiotherapy? You give small voltage current to the patients, just like you do in electrophysiological testing. Now you give small voltage current. This current stimulates the nerve to grow. So you know the prognosis is good, you just want to decrease the recovery time, so you give electrophysiotherapy, stimulate the nerve to grow further. Okay, so this is how we treat for Bell's palsy. I have told you step by step treatment so that you have different questions in the exam, you can mark the answer to every question. Okay, so that was the Bell's palsy and also the herpes zoster oticus, Ramsay-Hunt syndrome. We also treat it on the same lines, and we always include antiviral in the herpes zoster oticus. Right? Okay, let's look at a question over here. Most common cause of facial nerve palsy, I just told you, that is Bell's palsy, and Bell's palsy is idiopathic. All right, so that is our answer in this question. Next, let's come to temporal bone fractures. Now, the temporal bone fractures can be of two types. Which two types? One which go parallel to the axis of the temporal bone. So, temporal bone outside to inside. Okay, that's known as longitudinal fracture. And one that goes perpendicular to the axis, transverse or perpendicular to axis. So, it is known as transverse fracture. So, along the length of the axis, longitudinal. Perpendicular or transverse to the axis, transverse fracture. Two types of fracture. Okay. Now, longitudinal fracture are more common. 80% of the fractures are said to be longitudinal. Only 20% are said to be transverse fractures. Okay. Now, the longitudinal fractures, they happen due to temporoparietal blow. Okay. So, temporal blow or parietal blow. Whereas transverse fracture, they happen due to occipital blow. Okay. So, temporoparietal blow, occipital blow. Right. Now, longitudinal fractures 80%, but only 10% of them have facial palsy. Okay. So, that means usually they do not involve the facial nerve. So, only 10% have facial palsy. Transverse fracture only 20%, but 50% of these transverse fracture will have the palsy of seventh nerve. It will damage the seventh nerve. Right. Let's look over here. This is the CT scan of the longitudinal fracture. You can see over here in this CT scan, this over here is the fracture line running. That's a longitudinal fracture. Okay, and this is the transverse fracture. You can see over here the fracture line is perpendicular to the axis. So that is a transverse fracture. Okay, if somebody asks you which is the most common type of temporal bone fracture, most common type of temporal bone fracture. Now you see the classification of longitudinal and transverse. This is an old classification. At that time we had only X-rays. So when we got the CT scan, we found that pure longitudinal and pure transverse are not that common, as we have the mixed fracture. So this is the third type of fracture, the mixed fracture. Longitudinal plus transverse. Look over here. Okay, look over here. You will see that this is the mixed fracture. You have longitudinal and transverse. Okay, this is the mixed fracture. Now, mixed fracture, we have approximately 54% of the fractures are mixed fracture. So therefore, this is the most common type of temporal bone fractures. Okay, mixed or combined. 54% of fractures, they have both longitudinal and transverse component. Okay, now, nowadays because of this CT scan, we do not classify them as longitudinal or transfer or mixed. We have a new classification. Okay, the new classification is otic capsule sparing and otic capsule involving. Otic capsule sparing and otic capsule involving fractures. So one that is sparing the otic capsule, you see otic capsule forms the inner ear, right? So otic capsule sparing means it is not, this fracture is not damaging the inner ear. Otic capsule involving, otic capsule forms the inner ear. So that means this fracture is now involving the inner ear. So one that spares the inner ear will have less complications. That means there will be no vertigo, there will be no sensory hearing loss, there are less chances of facial palsy. Those fractures which involve the aortic capsules, that means they will have more complication, more chances of sensory hearing loss, vertigo, tinnitus, and facial palsy. So, aortic capsule sparing and aortic capsule involving, this is the latest classification. All right. Okay. Now, we have a patient of road traffic accident. This patient of road traffic accident comes to us and has a facial palsy. Okay. How will we decide what treatment to give? How do we decide what treatment to give? Okay. Now, this treatment depends upon a lot of factors. Which factors? Let's say after the RTA, patient comes to us and patient has complete, okay, patient has complete and immediate facial palsy. Okay, so complete immediate facial palsy. That means the facial nerve is cut. Okay, that means the facial nerve is cut. Okay, and when the facial nerve is cut, you have to immediately go for repair of facial nerve. Okay, so that means you have to go for surgery. Okay, you may have to take out the nerve from its bony canal and then you have to repair the nerve. You have to stitch it or you have to put a graft in between. So you have to do a surgery such as surgical decompression. Okay, surgical decompression followed by grafting also if required. Okay, so that is your surgery. Now let's say we have a second scenario. Which scenario? The patient presents to us with, at the time of injury there is no palsy. Patient comes to us with delayed palsy. Palsy started after the first or second day. So let's say on the third day the palsy started. Okay, and by 7th day it became complete palsy. Now you see, at the time of injury there was no palsy. Okay, or immediately after the injury there was no palsy. So what happened? By 2nd or 3rd day, because of the edema, you see the tissues around the facial nerve will undergone palsy. So because of the edema, now the facial nerve get compressed in its bony canal. Because of injury there is edema, and because of this edema facial nerve is compressed. So this is a situation just like Bell's palsy. Facial nerve is compressed in its own bony canal. So what do you do now? Now you will wait. Okay, now you will wait, and what will you do? You will give medical management. Okay, now you will wait and you will do medical management. Number 3, let's say we have a incomplete palsy. Okay, patient comes to you with incomplete palsy. It is not complete. Okay, so now what do you do? That means some part of the facial nerve is actually intact. The other part may be compressed, may have undergone edema, or may have been cut. You don't know that. Okay, so what will you do in incomplete palsy? In incomplete palsy, you will wait for at least 3 days. You will start with the medical management to reduce the edema and you will wait for 3 days. After 3 days, you can do the electrophysiological nerve testing. Okay, you can do the electrophysiological nerve testing from 3rd day to 14th day. You can do those tests and they will tell you what is the prognosis of the facial nerve. If the prognosis is poor, you may go for surgery. If the prognosis is good, you wait. Okay, this is what we do in case of incomplete facial palsy. This is how a patient of RTA is managed. Now remember, surgical decompression, immediate surgical decompression is done only when the facial nerve, there are 2 criteria. Which 2 criteria? Both have to be fulfilled. Number 1, it has to be a complete facial palsy. Number 2, it has to be immediate facial palsy. In that only you will go for surgical decompression. Okay, in remaining you wait and watch. Right? This is after a road traffic accident. Now this facial palsy can also happen in a case of surgery. Iatrogenic facial palsy. Okay, most common iatrogenic cause of facial palsy is mastoidectomy. Most common iatrogenic cause of facial palsy is mastoidectomy. Okay, which is the most common location for this iatrogenic injury? Most common location is the mastoid segment, the vertical segment. All right, just after second genu. This is the part which is most commonly injured during mastoidectomy. Okay, remember that just before second genu. So just before second genu, it will be tympanic segment, the horizontal segment. Just before second genu, the tympanic segment. Now this is the place where we have a normal facial, the fallopian canal dehiscence. Okay, so many a times approximately 30% patient may have a fallopian canal which is the bony wall is dehiscent, it is absent in approximately 30% of people. In which part? In the tympanic part, just before the second genu. So that is a part where many a times the facial nerve is lying naked, bare, without the fallopian canal. Okay, so that is in the tympanic segment just before the second genu, and just after the second genu is the most commonly injured part during mastoidectomy. Right? Okay. Now let's come to some other syndromes. We have the Melkersson-Rosenthal syndrome, also known as orofacial granulomatosis. Now, this Melkersson-Rosenthal syndrome, it consists of three things. Number one, there is non-tender persistent lip swelling. So you can see over here, there is persistent lip swelling over here. Number two, patient has lower motor neuron facial palsy. So you can see on this side, there is lower motor neuron facial palsy, complete half facial palsy. And number three, patient has fissured tongue, lingua plicata. Okay, patient has fissured tongue, lingua plicata. Together they form the Melkersson-Rosenthal syndrome. Okay, next we have Mobius syndrome. Now Mobius syndrome is congenital 7th and 6th nerve palsy. Okay, many a time this may be a bilateral palsy. So patient has moon-like faces, and you are not able to diagnose because it is a bilateral facial palsy. So there will be no deviation. Both the parts will be same. The right side and the left side will be same. There will be no deviation because it's a bilateral palsy. So Mobius syndrome, most of the times it's a bilateral palsy, congenital 7th and 6th nerve palsy. Now such a syndrome can also occur when there is a forceps delivery. Okay, because of that the 6th and the 7th nerve may undergo palsy. Alright, so now this question has been asked, which cranial nerve are affected in the Mobius syndrome. So we just said that the 6th and the 7th, the facial nerve and the 6th abducent nerve, both are affected in the Mobius syndrome. Right? Right. Next we come to the Fraze syndrome. Now the Fraze syndrome is also known as bilarger syndrome or Dupuy syndrome or auriculotemporal syndrome or Frey-Bilarger syndrome. So this syndrome, as the name suggests you, it involves the auriculotemporal nerve. Right? Now we have already studied a lot of information about the auriculotemporal nerve when I was teaching you the anatomy of the facial nerve. We know auriculotemporal nerve is a branch of mandibular nerve, 5th cranial nerve. Okay, but this auriculotemporal nerve, okay, it has the sympathetic fibers from the mandibular nerve, but it also has the parasympathetic fibers which it has stolen from the lesser petrosal nerve, 9th cranial nerve, glossopharyngeal fibers, remember? Okay, now you see these parasympathetic fibers along with some sympathetic fibers, there you can see they supply the parotid gland, and you can see the sympathetic fibers, they supply the sweat glands over here. Okay, right? So you see the parasympathetic fibers are not supplying the sweat glands. Only the sympathetic fibers are supplying the sweat gland. Now this is the normal condition. Alright. Now what happens if this auriculotemporal nerve is injured? Now this nerve may be injured in many surgeries such as parotid surgery, or it may be injured in rhytidectomy surgery. Rhytidectomy surgery is a facelift surgery to remove the facial wrinkles. Now what can happen if this auriculotemporal nerve is injured? This auriculotemporal nerve is injured in surgery such as the surgery of parotid gland. So what happens? Now you see over here, if the recovery happens, when there is a recovery, these sympathetic fibers, okay, and the parasympathetic fibers, they get intermixed during the recovery. Okay, so now what happens, as you can see over here, they become mixed fibers, and now the mixed sympathetic and parasympathetic, they're supplying the sweat glands and the parotid gland. Okay, that means if there is a stimulus, to secrete the saliva, you try to eat something, there is a stimulus to secrete the saliva that has to go to the parotid gland. Now it will also go to the sweat glands. Okay, so what will happen? The patient will have flushing. Alright, this area will become red, there is a flushing and there is increased sweating. Above this parotid gland, this area, there is flushing and sweating whenever the patient tries to eat something. That's known as Fraze syndrome. Right? Look at this patient. This patient had a parotidectomy. You can see this wonderful parotidectomy scar. Okay. Now when the patient tries to eat something, what happens? What do you see? You see all this area, there is increased sweating and there is flushing. Okay. So this is the Fraze syndrome. Right? Now, question. Which of the following nerve is damaged in Fraze syndrome? When this question is asked, your answer is auriculotemporal nerve. So that is our answer to this question. But suppose I change the language of this question. How can I change? Let's look at another question. Fraze syndrome occurs due to aberrant misdirection of fibers from the salivary glands to sweat glands. We know this. These fibers come from which of the following nerves? So we know that these fibers, the parasympathetic fibers, which were supposed to supply the parotid, now they are supplying the sweat glands. These fibers are brought by auriculotemporal nerve, branch of mandibular nerve, but these fibers have originally been taken from lesser petrosal nerve, which has taken these fibers from the glossopharyngeal nerve, the ninth cranial nerve. So that is our answer to this question. Okay, these fibers, they come from the glossopharyngeal nerve. So you have seen there are two questions. Which nerve damage? Answer is auriculotemporal nerve. Okay, now this nerve is carrying the fibers of which cranial nerve? Glossopharyngeal nerve. Okay, got it? Alright. Now, always remember, you see the tongue. I always tell the tongue. There is an analogy in the tongue. You see, tongue anterior 2/3 is supplied by chorda tympani. That is the branch of 7th cranial nerve. The posterior 1/3 is supplied by glossopharyngeal nerve. Similarly, look at the salivary glands. Now, there are three major salivary glands. Two anterior salivary glands. Which one? Submandibular and sublingual. Both were supplied by chorda tympani. Okay, and one posterior one. Which one? The parotid. And parotid is supplied by the fibers of 9th cranial nerve. Okay, so there is the analogy between the tongue supply and the major salivary gland nerve supply. Alright, okay, let's come to the treatment of the Fraze syndrome. So how can we treat the Fraze syndrome? Number one, we can put some antiperspirant that will decrease the sweating, such as aluminium chloride. Okay, that will absorb the sweat, it will decrease the sweating. Number two, we can inject botulinum toxin. So we inject it into the affected tissues, so that will stop the secretion of the sweat. Okay, so we can inject botulinum toxin, but botulinum toxin, it works for 3 to 6 months. So we have to give repeated toxin, and this is a costly affair for many patients. Okay, one vial of this botulinum toxin, it may cost between 16 to 20,000 rupees. So that means every 3 to 6 months patient has to spend this much money. Okay, other than that, we can also do some surgical treatment, such as you can put a fascia lata between the skin and the underlying fat. So this you can do as a primary treatment after periodectomy if you suspect there is a auriculotemporal nerve injury, or you can do it post surgery once again if there is a Frey syndrome. So to treat the Frey syndrome, you can do the fascia lata insertion. Number 4, you can do tympanic neurectomy. So you see the glossopharyngeal nerve fibers, they join the lesser petrosal nerve which is coming from the facial nerve in the middle ear. So you can cut the tympanic branch of the 9th cranial nerve. Which branch? The tympanic branch of the 9th cranial nerve is the Jacobson's nerve. So this is carrying the 9th nerve fibers. It gives it to the tympanic plexus, and from there they go and they join the lesser petrosal nerve. So this nerve is cut over there, and therefore the Frey syndrome will go away. Okay, so different ways where we can treat the Frey syndrome. Okay, next question. All of the following are true statements about Frey syndrome except gustatory sweating. Yes, that's a true statement. Aberrant misdirection of parasympathetic fibers of auriculotemporal nerve. That is also a true statement. Okay, so these parasympathetic fibers of auriculotemporal nerve, now instead of supplying the parotid, they also start supplying the sweat gland. Botulinum toxin is one of the treatments suggested. Yes. Okay, less chances of with enucleation than periodectomy. There is no difference. This statement is wrong. Okay, there is no difference. As soon as you give the incision, you can cut the auriculotemporal nerve. So whether you do enucleation or you do the complete periodectomy, there is no difference. Right? Okay, so answer is 4th. Okay, we have to find out all are true except. So therefore our answer is the 4th D choice. Right? Okay, right. So those were the questions which can be asked about the Frey syndrome. Let's go to the crocodile tear syndrome. Now, crocodile tear syndrome is also known as Boger-Rat syndrome. Let's say the facial injury has happened above the first genu. You know what arises from the first genu? The GSPN. Okay, what arises from the first genu? The GSPN. Now, if the injury has happened at or above first genu, now what happens? Now, there is a intermixing of fibers. Okay, there is a intermixing of fibers. So, what happens whenever the patient tries to eat food? You see, there is a taste sensation. So, whenever patient puts the food in the mouth, there is taste sensation. So, that is under the control of chorda tympani. Okay, now what happens when this aberration happens? Now, because of that, whenever the patient tries to eat food, puts the food in the mouth, there is taste stimulation, and that stimulates the GSPN. There is lacrimation. That is known as crocodile tear syndrome or Boger-Rat syndrome. This is when the facial injury happens above the first genu. Okay, and we have seen the most common cause is Bell's palsy. All right, so after Bell's palsy, we can have this syndrome, the crocodile tear syndrome. Now, these were the different syndromes that I wanted to discuss along with the facial palsies. Now, before we finish the topic, let's look at a few conditions that cause recurrent facial nerve palsy. Now, the most important once again is Bell's palsy. Okay, 3 to 10% cases can have a recurrence of the Bell's palsy. Right? Now, similarly, we can have a recurrence of the Ramsay-Hunt syndrome also. Right? Other than that, there is sickle cell disease. We have tumors which can cause recurrent facial palsy. There is Behcet syndrome. Melancthon-Rosenthal syndrome also have recurrent facial palsy. Right? Okay. Now we come to bilateral facial nerve palsy. Okay, so bilateral facial nerve palsy, once again, many a time patient can have bilateral Bell's palsy. Okay, so bilateral Bell's palsy is one of the cause. Then the other causes like Guillain-Barré syndrome, Lyme disease, sarcoidosis, meningitis, brainstem encephalitis. Okay, there is intracranial hypertension, leukemia, etc. Now remember, Lyme disease over here is one of the infective causes of bilateral facial nerve palsy. Okay, remember, this is one of the infective causes of bilateral facial nerve palsy, right? Other than that, I have already told you the Melchior-Rosenthal syndrome can also have bilateral facial palsy, diabetes, HIV infection, syphilis, infectious mononucleosis. So just to complete the list, Mobius syndrome we have discussed, they have bilateral 6th and 7th nerve palsy, and patient can even have bilateral neurofibromas. Okay, so this was the bilateral facial palsy. Okay, next we come to the House-Brackmann grading. So this is the last thing we have to discuss in the facial nerve disorders, and it is important because it comes as an MCQ. Now the House-Brackmann grading grades the types of facial palsy, and it is graded from 1 to 6. Okay, so there is a very easy way to remember this chart. I'm going to tell you the easy way to remember this chart. Okay, very easy, and quickly you can grade if a question is given to you. All right, so now 1 you see over here is a normal person. I'm not going to describe the whole table. We're just going to learn how to remember this table. So 1 is normal patient and 6th is total palsy. So you know, normal patient, you and me, we are 1. 1 means normal. Okay, 6 means total palsy, no movement at all. Right? So 1 normal, 6 total palsy. Right? No movement at all. Okay, now 3. You see 3. 3 is important thing over here is complete eye closure with effort. Okay, complete eye closure with effort, that is your grade 3 facial palsy. That means till grade 3 the patient is able to completely close the eye. That is important. Why? Because in grade 4 the eye closure will be incomplete. So grade 4, 5, 6 eye closure will be incomplete. Now that is the first thing. Okay, so whenever you have a question, what is the grade of this facial palsy, look at the eye. That is how I do. Okay, I have a patient, first thing I look at the eye. Eye closure is complete, it is grade 3 or grade 2. Okay, eye closure is not there, it will be grade 4, 5, 6. Right? Okay, now if you have grade 4, now you see grade 4 and grade 5, you see in grade 4 patient still has normal symmetry and tone at rest. So if the patient is not smiling, okay, if the patient is not smiling, patient is not speaking, you will not find patient has any problem. Okay, patient will have asymmetry at rest in grade 5. Okay, in grade 5 this nasolabial fold may be missing. So even when the patient, the mouth is slightly deviated to one side, to the opposite side. So in even rest in grade 5 you will find the asymmetry. Otherwise in grade 4 there is normal symmetry and tone at rest. Okay, so if you know this thing, you can grade the facial nerve palsy. Okay, and before we finish, now this is a photograph. It went viral for Priya Prakash Warrior, and she was winking. So now she is winking. If you take this just one snap, you see, what do you see? You see that there is a loss of frontal wrinkles. There is no wrinkles over here. Okay, the eyeball is rotated up. In grade 6 palsy, to protect the eyeball, you see, what do you see? The eyelids have drooped, and whenever the eyelids close, the eyeball, it rotates up, but that's known as Bell's phenomena, and it is quite visible in grade 6 palsy. So this is to protect the cornea. The eyeball always moves like this. This This phenomena is visible in grade 6 palsy. So you can see the eyeball has rotated upwards. Then you can see there's a loss of the nasolabial fold and the mouth has deviated to the other side. Okay, so in this look, it looks like as if the patient, she's having a grade 6 facial palsy. Okay, right? It's a lower motor neuron palsy because complete half facial palsy. Okay, so that looks like a grade 6 facial palsy in Priya Prakash. All right. Okay, so that was the facial nerve disorders. Thank you.